Hey everyone, this is Joe Minardi coming to you live from the WVU Emergency Medicine Recording Studios, and I've got a few things to talk to you about on ultrasound of lower extremity DVT. So we're going to jump right on in. I don't have any disclosures. If you want to send me money and get me to hawk your items, I certainly will. Here's some objectives. So I want you all, when you're done with this, to know when you should do an ultrasound for lower extremity DVT, how to do it, how to recognize the normal anatomy, and what the findings of DVT are, and then how to look for and avoid some of the most common pitfalls. See, I told you I'd be fast. So why? Why do we care? So DVT, this is a common thing, right? It affects a wide range of medical and surgical patients, and it's very commonly on our differential diagnosis. And by doing this quickly at the bedside, we can save time, money, resources, and as you're going to see, this is really easy. You can do this. So who should we do this on? Patients with leg pain or swelling, or maybe they have signs or symptoms of pulmonary embolism, and this is maybe part of your staged workup. If you're a medical student or if you're a beginner to this type of ultrasound, really, who should you do it on? Anybody that's got legs, okay? Practice will make you good at this.
Okay, so you might be asking yourself, so how is looking for leg DVT part of a workup for PE? Well, the simple answer is, say you have the patient who, for some reason, can't get an immediate CT pulmonary angiogram, which is our usual study of choice to work up pulmonary embolism. And this is someone who maybe they're pregnant, so you're not anxious to rush them off for CT and a big dye load and a lot of radiation. Or maybe there's a problem with dye. They've got a documented allergy, got bad kidney disease with a creatinine of 7, and you can't send them for a CT PA right now. Or maybe they're just too unstable to go over to the CAT scanners. These are people where doing the DVT study can serve as diagnostic and as part of your workup for possible PE. And so let's kind of talk through how that might work. Okay, so you've decided that you're worried about pulmonary embolism, but for some reason you can't get the patient over for a CT pulmonary angiogram right away. Now, just to be clear, when we're talking about working up pulmonary embolism at the bedside using ultrasound, it's more than just looking for DVT. So when we're looking for PE at the bedside with ultrasound, it should include a DVT study, but also looking at the heart, doing an echo to look for a dilated right ventricle, or maybe even you see clot in transit, and then looking at the lungs for evidence of pulmonary infarcts. And it's been shown that doing this multi-system study with ultrasound to look for PE can be pretty accurate, but this is beyond what we want to talk about today, so we're just going to drop those out of there. So, and overall, this is a complex topic. There's lots of things to consider, so we're going to try to make it simple and kind of stick with our focus on DVT, which is our real goal today. But the simplified algorithm is you have a patient where you suspect PE, right? So if you suspect PE, then you can do the DVT study as part of their workup. And if that DVT study is positive, then that supports a decision to treat. Now, what treatment you're going to use depends on the rest of the clinical picture, some of the other information that might be available by ultrasound, but treatment with some kind of anticoagulant if they're not terribly sick, or it might support a decision to go ahead and administer systemic thrombolytics in a patient where PE is highly suspected and they kind of meet other clinical findings that would suggest that IVTPA is the right therapy for them. Again, beyond the scope of what we want to talk about now, but something to think about, and this is how you can use DVT study as part of this workup. If you suspect PE and you do the DVT study of their legs and it's negative, then that supports you in a decision to withhold treatment. Now, if you're withholding treatment, then you might decide, all right, well, I'm still worried enough, I'm going to delay treatment, but I'm going to try to get, maybe I need to hydrate this patient, maybe I need to do a pre-treatment allergy protocol and do a delayed CT pulmonary angiogram. Maybe I need to get them where they can get a VQ scan, or you might decide, you know what, with no evidence of DVT, everything else looks like it's low risk, maybe I can just withhold treatment altogether and be done with this workup. But that, again, that's a complicated decision. There's lots to think about. I don't want to get too much into the weeds of that discussion now. So let's move on.
So the risk factors for DVT, I don't want to spend a ton of time on this, but they all kind of fall into these categories of stasis, injury, and hypercoagulability. And as you'll see, some of these things kind of overlap. So, stasis, immobility, surgery, long plane trips or car trips, injury, trauma. There's direct and indirect trauma. We're not going to get into a lot of details on that. And then all these things, and the list goes on and on about things that make people hypercoagulable. And these are things that you all know about. I'm not going to spend a lot of time talking about it. So just quickly, what does some of the literature say about a bedside abbreviated ultrasound for diagnosing DVT? Well, pretty much here's my layman's summary of what the literature says, is that it's easy, it's quite accurate, and that this ultrasound that I'm going to teach you, I sometimes refer to it as 3-point, sometimes we hear it called 2-point. There's some differences in some of the papers, but the study that I'm going to teach you has been shown to be pretty much equal to a whole comprehensive leg ultrasound and equal as far as treatment algorithms in most patients. So there is a little bit of a disclaimer I'm going to talk about. I'm talking about you see a patient, you ultrasound them, and then you either send them home or you start treating them for DVT. What is recommended by a lot of people who are smarter than me in big panels is that you do a history and physical, you risk stratify your patient, and then probably order a D-dimer, and then use that D-dimer result to decide on whether you're going to image them with ultrasound or not. However, in my life, and in a lot of people's lives that work in clinics or urgent cares or even in the hospital, if you walk into the room with an ultrasound with you, you can usually do this and be done much more quickly than you can wait on a D-dimer to come back. So that's the way I use it, but just know that that's what's out there. So let's get right into how you're going to do this. You know about probes. We're going to choose a high-frequency linear probe, and that's going to work for most of our patients. And the patient position, they're usually going to be supine. Sometimes you can have a little bit of trouble if you try to do this with them sitting up too much. So I just recommend getting them all the way supine if possible, just from the get-go. And it helps to get their hip a little bit externally rotated and maybe slightly flex their knee, kind of what you see over there. All right, so when you first start, and in this patient we're going to start on their right leg, the indicator is to your left. You are facing your patient's face and you're facing the screen, hopefully at the same time. Indicator is to your left or the patient's right, and you're going to start in their inguinal crease. Then you're going to identify some of their anatomy. You're going to start off by finding the saphenofemoral junction. The saphenous vein is going to be medial, proximal, and superficial to the femoral vein, and depending on which side you're on, it'll be on a different side of your screen. And then really you're just checking, is that vein compressible? Yes or no? That's the question, that's the key question that you want to ask. And very important that when you compress this vein, you're pushing straight up and down on it. You don't want to be pushing at funny angles, because then you'll be pushing at a different plane than you're actually looking at on your screen. So let's watch a quick little demo of this dude here, who I think probably it's his first time ever doing an ultrasound, but see if he knows what he's doing. So right in that inguinal crease, kind of following the plane of the inguinal crease. And we fan kind of towards the patient's head until we find that saphenofemoral junction. I'll show you what that looks like here in a second. And look at that. Compress. Straight up, straight down. Straight up, straight down. Straight up and down. And you can see you're right in the groin. This is a familiar spot for the patient. Helps to have hairy arms. So here's what this anatomy looks like. So just a couple of reminders of veins versus arteries. Remember, veins should collapse before arteries do. Arteries have thicker walls. They usually pulse. Hopefully they pulse. And they resist compression. You can compress them if you press hard enough, but usually the veins should collapse well before the arteries do. And then the veins have thinner walls. They don't pulse in the same fashion that arteries do, and they should collapse. So just some reminders of this anatomy. So if this is the right side, remember the artery should sit lateral, so femoral artery here, femoral vein, and then saphenous vein kind of makes that whole Mickey Mouse thing. That's kind of your first point where you start with your leg ultrasound. And then here's what it should look like. You see how the artery here doesn't really compress. These veins compress quite well. And also just point out that down here you see bone. You see kind of bright white and shadow. That's another thing to look for. Make sure you're looking at deep veins. Just a couple more demos. Note the difference between right and left. The artery is lateral. On the left here, artery lateral. Your indicator stays to the patient's right, regardless of which side you're doing. And also point out down here, there's bone and shadow, so we're looking at deep veins. You see the veins collapse, arteries resist compression. And you even see, if you're wondering, some little valves here in these veins. That's what you're seeing flickering inside there.
Okay, so the next step is that you want to follow that femoral vein a little bit more distally. So most superiorly or most towards the head, you found the Saphenofemoral junction and everything compressed there. Now you want to follow the femoral vein a little bit more distally to identify the bifurcation of the superficial and deep femoral veins. The deep femoral vein is a place where we can miss clots if we're not careful, so we want to follow it down until we see it and clearly identify that it's patent. So what you're going to do, use the artery as your guide. As you follow the vein down, you're going to see multiple branches. You may see an arterial branch, and that's okay as long as you know it's artery, doesn't matter. And you may see some other, sometimes there's some arcuate veins or some laterally branching veins from the femoral vein. If you see those, you want to make sure they collapse and that they're patent. But the key thing is that you want to see the deep femoral vein, and we're going to focus on that. So the deep femoral vein, one characteristic about it is that it typically splits off almost vertically from the superficial femoral vein, and we're going to demonstrate that here. So here's the artery, here's the femoral vein, and here's the deep femoral right here. We want to get down to where we can see that, make sure that's compressible up and down. And just to diagram that and make this anatomy a little more clear and show you exactly what's going on, and this is what you should train your eyes and your hands to look for with the probe. We'll see the femoral artery. This may be the superficial femoral artery depending on exactly where the splits occur. Then we're going to see the superficial femoral vein, and coming off just underneath it, almost vertically in most cases, is the deep femoral vein. We want to identify that and then make sure that it is indeed compressible.
Then next, you're going to go into the popliteal fossa, and just reminders, you're going to get right in that fossa, right in the crease, perpendicular to it. You're going to find the artery, find the popliteal artery. That's very important. And then check compressibility of the vein. And once again, we'll see if this novice sonographer knows what they're doing. Right there, right in the crease. And this is great camera work too, I'm just going to point out. Vertically, pressing in on the vein and checking for compressibility. Now we'll look at what the veins might look like on the screen to see what that looks like. Here's a rapidly flashing screen, but I wanted to point out to you here, popliteal artery is deep, so that's an important piece here. Then the vein sits on top of the artery on the screen generally. Then there's some other things that can distract you, these superficial veins that I don't care what they're called, I don't care about looking at them, I really only care about the popliteal vein. And then you also may notice the tibial nerve in this view as well. Now let's see what that looks like before somebody has a seizure. So here's our popliteal artery. Vein is on top. We can see as we compress, bone and shadow comes into view, so we know we're deep enough, or it's a clue that we're deep enough. Superficial veins here that compress, which is good. I don't care about those though. Don't let those distract you from the real veins. And then there's tibial nerve. But this vein, it compresses and the artery doesn't, so it's nice and normal.
So once we've identified the popliteal vein in the popliteal fossa, we want to fan a little bit proximally and distally and identify the branch points or the trifurcation of the popliteal vein. And the trifurcation is where it splits into the posterior tibial, anterior tibial, and the fibular or perineal veins. The names aren't really that important. The importance is we want to see the main branches and the branch points, because branch points are areas where clots tend to hang out, and we want to make sure we see those. By being diligent and making sure that we see not just the popliteal vein, but also the trifurcation branch points and making sure these are compressible, we've done a more complete study, and adding all of these components together, which only takes another 10 seconds or so each, makes our study a lot more accurate and drastically increases the sensitivity of our bedside DVT study. So let's just take a look at what these look like. So the deepest is going to be the popliteal artery, and then we've already tracked up or down, so we see posterior tibial vein, which splits to the perineal, and then the anterior tibial vein. Now again, the names aren't really that important. Find the popliteal vein, track it up and down until you see trifurcation and the 3 branch points of the popliteal vein. And here's what that may look like. We can see the artery deep and the branches of the vein all collapsing nicely as they should.
All right, I'm going to show you a couple of quick pieces of bonus material. These are not definitive answers to the questions we're asking, but they can give you a little bit of added information. So two things: augmentation. This is a technique that helps you assess the patency distal to the vein that you're actually looking at, and then phasicity, also known as respiratory variation. This gives you some clues as to the proximal patency of the vein that you're looking at, and I'll show that to you. So what you do to check for these things, for augmentation, you just find your vein. So here's our vein right here. We've stuck our pulsed wave Doppler gate right in that vein, and then we squeeze somewhere distally on the calf, and then on our velocity graph here, we should see a little spike because that blood has rushed up into that vein from where we squeezed, and that is a marker that distally it is patent. If it was blocked by a clot, we would not get this spike, or not as strong of a spike, and that would be a clue, not a definitive answer, but a clue as to a blood clot. Remember, this suggests distal patency. Suggests is the key word. And then phasicity. For this, we kind of do a lot of the same thing. We get our vein of interest, we stick our pulsed wave Doppler gate in here. This works better the closer you are to the patient's diaphragm. But then we just tell the patient to breathe normally, or we can have them take a couple of deep breaths in and out, and we'll see on our velocity scale here, we just see some kind of wavy up and down motions as the venous flow velocities change during respiration. And that's just because of the changes in intra-abdominal pressures as the patient breathes, causes changes in pressure and velocities in the blood moving in the veins. Now this gives you clues as to the proximal patency. If there was a clot in your proximal iliac vein, just above where you have your Doppler gate, then you would expect not to see as much of this because that respiratory change in pressure would not be transmitted to that vein. This may not be quite as visible down distally in the popliteals, but should be visible in most patients in the femoral area. Especially make sure they're laying flat. If they're sitting up at 90 degrees, you might lose a lot of this. Now just a couple of these, so that was it. That's pretty much how you do the study. You can see that is really pretty easy. Find vein, make sure it's next to artery, see if it compresses or not. That's it. Then there's the bonus material, augmentation, and phasicity that you can look for some added info. And then there's just a couple things that trip people up commonly over and over, things you'll see, and I want to show you these so you can hopefully skip these little pitfalls. So one of the most common things is people look too superficially and pay attention to veins that aren't really the veins of interest. So I'll show you how to kind of avoid that. Then lymph nodes. Sometimes a lymph node can look kind of like a vein with some clot in it. I'm just going to show you some examples of those so you can recognize them and try not to mistake those for clotted veins. Usually if you make sure you're right next to the artery, you're going to be able to avoid that. And then another thing that mistake people make is sometimes they don't compress vertically. If you compress at a funny angle, remember your compression angle and your viewing angle on your screen are going to be different planes, and you won't really be compressing what you're seeing on the screen. That can just throw you off. So compress straight up and down on your veins. So here's one. This is a mistake that someone sent to me a while back, where someone did this DVT study and they saw these veins here and they said, oh, they look like they're compressing. I think it's probably pretty good. Here's another one here where I think maybe that artery, I don't know, that vein looks like it compresses a little bit. Maybe it's okay. These are all wrong. And one of the biggest mistakes here was they just didn't have their machine set deeply enough, and they weren't quite careful enough at finding the arteries and some of the other landmarks. So I'll show you the correct example, but what we've got here, actually this is the deep vein, but we don't see the whole thing because we don't have enough depth, and it's incredibly clotted. And here, we're kind of focused on these on the screen, but our deep vessels are down here and they're cut off on the screen. We're not even really imaging the proper vessels. So checking for the artery, making sure you have enough depth are going to help you avoid this pitfall. So here, this is the same patient. Here are the veins we were looking at before. All we've done is increase our depth, so we're seeing a lot more info. And the artery is actually here, and this is this giant clot in the femoral vein that you just can't compress at all. Somebody was actually sitting on this probe, and they couldn't get this thing to compress. And this is another patient here. See, these are the veins. This is the corrected view. This person had been kind of focused on these. They weren't sure, but just increasing the depth, and we can see here are the proper artery here, vein here, and this vein also doesn't compress. So this patient has DVT in their femoral, and same patient, popliteal. And you can even see, usually as you compress here, you start to see bone kind of sneak in at the bottom. There's a little bit of bone sneaking in at the bottom of the screen, so that helps you know I'm looking deeply enough. And then lymph nodes, they can be something, can mistake a little bit for clotted vein. So we've got one comes into view right up here, and you can see it kind of looks like a vein, but if you pay attention, you see, oh, there's the artery, and here's our vein compressing, so that's probably not anything. And if you scan all the way up and down through it, it'll disappear, whereas a vein shouldn't disappear. It should continue down the leg. Here's another one, comes into view right here. You see it's kind of got that bright white fatty hilum in the middle, so that's a clue that it's a lymph node. And here, this is a tiny, probably more normal lymph node that's not very swollen, but you can recognize that separate from, here's one of your vessels over here. So those are what lymph nodes look like. Scan all the way through them and look for the relationship next to the artery and the depth, and you can avoid this as one of the pitfalls. So some circles around those for you. So pitfalls, ways to avoid them: superficial veins, make sure you're deep enough. Always, at least when you're first starting to look, err on the deep side, and then you can decrease your depth as you identify your anatomy. Find the artery, find the deep artery, and look for the vein nearby. Deep veins are always very close, usually almost touching deep arteries. So if it's not touching a deep artery, it may not be the right thing. And look for the bone. If you're deep enough to see bone somewhere, then you know you've probably got enough depth. Lymph nodes, just scan all the way through them. If you stick color on there, the lymph nodes shouldn't really they have a little bit of color that runs into the hilum, but they shouldn't have a lot of color. Look for the artery, again, look for the relationship, scan all the way through. That'll help you avoid lymph nodes. And then the way to avoid the non-vertical compression pitfall is, you guessed it, compress vertically. So just some examples. So I'll let you look at this for a second. Is this a DVT? Yes or no? This is the left leg, so this should be artery here laterally. And so yeah, you guessed it, this is a DVT. There's your vein that doesn't compress very well. Here's another example. Get that going. Is this a DVT? Yes or no? Play some more for us, come on. And of course, this is a non-collapsing vein, so this must be the patient's right, because we have the artery over here. And we've got another one. We may have to play this a few times. DVT, yes or no? What do you think? Where's your anatomy? Where's the artery? Where's the vein? And the answer is yes, this is a DVT. So popliteal artery here is deep, and here is the popliteal vein. It doesn't compress. So again, we have found a DVT. What do you think? Looks like we probably could have compressed a little bit harder, but once again, we're on the right side, so our artery is here lateral, and there's our vein that does not compress. Remember, don't rely on seeing the clot. A lot of times you may not see clot, or sometimes veins may look like there's a little bit of echogenic stuff in there and there's really nothing. So compressibility is the question, not whether you see clot in there.
Okay, so we've got one last example here. We'll take a look. It looks like we're in the popliteal fossa. Here's the artery deep. And what do we see here? Well, what we see is a vein that doesn't collapse, and you can actually see some visible thrombus sitting in there. So it's a non-collapsing deep vein. So yes, this is yet another example of DVT.
That's pretty much it. So those were all positives for those of you that didn't notice that. Some other things to think about: if you have a patient and you do a study on them and it's negative, almost everybody should have follow-up. If they have persistent symptoms, they should probably have repeat imaging. Roughly a week is what I usually tell people. And then remember, there are still, even in a vascular lab that does 1,000 ultrasounds a day, there still is a small miss rate. So patients that are very high risk and very high suspicion, even with a negative ultrasound, no matter who does it, vascular lab, but no matter who does it, if they have a negative ultrasound and still have really high suspicion, really high risk, they may warrant some other imaging like venography. Probably this day and age, we're doing CT venography more often, but that's something to think about. Sometimes there are false negatives, even no matter who's doing the scan. So that's pretty much it. I hope you see that this is pretty easy. Anybody can do this, and you can diagnose people quickly, get them in and out. You can avoid extra ER trips, avoid hours of delays and waiting on scans to be done and read, or waiting on anticoagulation, or you can avoid anticoagulating people who maybe don't need it by just walking into the room, see the patient, do history and physical, do an ultrasound, diagnosis or excluded right there, right then, done. So it's easy, it's quick, it's accurate. When you're doing the scan, make sure you find the deep arteries. That will help you find the veins. Compress up and down vertically and ask yourself the question, do they collapse, yes or no? That's it. Hope that helps, and hope to see you in the labs. Thanks.